Welcome back, everyone. We have learned in our previous videos about the introduction and the pathogenesis of tuberculosis, how to diagnose tuberculosis, how to investigate, how to manage drug sensitive cases of tuberculosis. Now, coming to the last two lectures, one today's lecture is about TB-HIV co-infection, which is a very important topic for exams also, and the last lecture will be about drug resistant tuberculosis. So the outline of today's discussion will be significance of tuberculosis with HIV co-infection, what are the problems in diagnosis and treatment of tuberculosis in children living with HIV, what is the 4 symptom diagnostic strategy, what is the management protocol for TB-HIV co-infection, what is IRIS, and how do we decide on the BCG vaccination in a neonate born to a mother with HIV infection. So TB and HIV, they go hand in hand. People living with HIV are 18 times more likely to develop active tuberculosis, and this active tuberculosis accelerates the HIV disease progression. Extremely high death rate is seen for patients with TB and HIV co-infection, that is 15 to 18%. And in children living with HIV, the risk of recurrent TB is higher, risk of serious drug interactions is higher. That's why HIV testing is to be offered to all patients diagnosed with tuberculosis. That information we learned in the previous video, and that's why the strengthening of 3I strategy is there. What is 3I? 3I means the first I stands for intensive case finding, second I stands for infection control, specifically airborne infection control, and the third I stands for isoniazid preventive therapy. About isoniazid preventive therapy we learned in our previous video about in the part 2 of the management of tuberculosis video. So what are the strategies for HIV TB coordination to reduce mortality? So there are mainly 3 strategies. First is prevention, second is early detection, third is early care and prompt treatment. So how do we prevent? That is isoniazid preventive therapy for all the children living with HIV, robust airborne infection control measures, and generate awareness about the TB HIV co-infection and the importance of both. Second is early detection of HIV TB co-infection. How do we early detect? We should provide provider initiated HIV testing and counseling. Rapid diagnostics need to be done for detection of TB and drug resistant tuberculosis, especially in patients with HIV, and intensive case finding activities has to be done in all HIV settings. Third is early care and prompt treatment of HIV TB. Single window delivery services may be there. That means patients should get all the medications, all the advice, all the counseling at a single point. Prompt initiation of antitubercular therapy must be done. Antiretroviral therapy for HIV TB irrespective of the CD4 count. Now the current guidelines, what are the current guidelines? When to initiate ATT, when to initiate ART, we'll learn that. Early ART initiation within 8 weeks. Why? We'll learn that. And travel support also has to be provided. So all the children living with HIV have to be screened at each visit for tuberculosis. How do we screen? First, we classify them into 2 groups, adolescents and children. Among the adolescents, we look for 4 symptoms. That is, if there is any current cough, that means is the child now coughing? Is there any fever? Is there any weight loss? Or is there any night sweats? That means we have to think about 4 symptoms. Likewise, in children also, we have to think about 4 symptoms, but they're slightly different. One is current cough, that is same. One is fever, that is same. Instead of weight loss, there is poor weight gain, because children means the child should continuously gain weight. But if there is poor weight gain, fourth is not night sweats. Fourth is history of TB contact. If these 4 symptoms are there, depending on adolescent or children, this is the 4 symptom screening strategy. In each group, we have to think about 4 symptoms. We have to ask if any symptoms are there. First thing is, if more than one symptoms are present, stamp the case as 4 symptom positive in register and green book and proceed to evaluate that case. But if no symptoms are present, stamp the patient as 4 symptom negative and register in the green book, and the patient has to be taken for routine flow and consider tuberculosis preventive therapy after ruling out active TB and contraindications, just like we discussed in our previous video. But on the other hand, if the child is 4S positive, that means 4 symptoms more than equal to 1 symptoms are present in this case, the patient has to be evaluated for TB. So we have to think about active tuberculosis ruling out. So we'll evaluate the patient for TB just like we'll evaluate in other cases. We have to do chest x-ray, nucleic acid amplification test, and other sites or other tests depending on extrapulmonary site involvement. If tuberculosis is not diagnosed, then what do? We do appropriate management as per the diagnosis and take the child for routine flu and consider tuberculosis preventive therapy. But on the other hand, when we do NAT and X-ray and all those things, if TB is diagnosed at any point of time, then we have to treat it as a case of tuberculosis. And depending on the sensitivity, because NAT gives us two reports, first thing is Mycobacterium tuberculosis is detected or not, then rifampicin resistance is present or not. So depending on the test report, will stamp the case as a drug sensitive tuberculosis or drug resistant tuberculosis. If the patient is a case of drug sensitive tuberculosis, we have to start ATT at ART center, document in white card and TB treatment card. But if the case is a drug resistant tuberculosis, we have to refer the patient to a drug resistant tuberculosis center. So this is the algorithm of 4 symptom screening strategy for tuberculosis in children living with HIV. So now coming to what are the problems in diagnosis and treatment of TB in children living with HIV. Why the TB HIV co-infection is important. In children living with HIV, we encounter following problems in the diagnosis and management of tuberculosis. First thing is overlapping symptoms. That means chronic pulmonary symptoms due to other HIV related conditions may be there. What are the other HIV related conditions? The symptoms of which may mimic those of tuberculosis. GERD, that is gastroesophageal reflux disease, bronchiectasis, interstitial pneumonia, weight loss, failure to thrive. All these symptoms may be present in HIV related conditions, and all these symptoms are symptoms of tuberculosis also. So overlapping symptoms may be there. So presence of these symptoms in a child living with HIV may be due to TB or may be due to other conditions. So that is a problem. Second thing is the interpretation of chest x-ray is difficult with presence of other HIV related conditions and can have normal chest x-ray also, because many of the chest x-ray findings are due to the immune mediated response of the body in response to the infection. As HIV is a immunocompromised condition, the chest x-ray may be normal, that is first thing. And second thing is the chest x-ray may be confusing because the interpretation will be difficult. Third thing is tuberculin skin test. The induration more than 5 millimeter is considered positive in a child living with HIV in place of the conventional 10 millimeter cutoff. And this tuberculin skin test is an extremely low sensitivity. So because the tuberculin skin test is basically a delayed type of hypersensitivity or delayed type of hypersensitivity reaction, but if the child is immunocompromised, that delayed type of hypersensitivity reaction may not be there. That's why a lower cutoff is taken. Next thing, sputum microscopy. The tuberculosis in a child living with HIV is possibacillary, so sputum microscopy may be falsely negative and it has a poor sensitivity. Higher incidence of extrapulmonary TB and sputum negativity as HIV progresses. As the HIV progresses, the disease becomes more severe. There is higher incidence of extrapulmonary tuberculosis and the sputum negativity also increases as discussed before, and the treatment is more difficult and the adverse effects are more common in a child living with HIV for tuberculosis rather than in comparison to a normal child or a child without HIV who is suffering from tuberculosis. But in spite of all that, we have to remember one line, that is nucleic acid amplification test is the frontline test for diagnosis of TB among CL-HIV, just like other conditions, just like other patients. But if NAT is not available, arrangements have to be made for collection and transportation of sample to the nearest NAT or MGIT culture site. So always we have to rely upon NAT for the diagnosis of tuberculosis in a child with HIV, just like we rely upon it in the other conditions also. So suppose an HIV infected child comes to us. First, what do? We do intensified case finding. It was one of the 3I strategies. Then we classify all the cases of presumptive tuberculosis into two groups: presumptive pulmonary TB or presumptive extrapulmonary TB, depending upon the signs and symptoms. In the presumptive pulmonary TB cases, we obviously have to do nucleic acid amplification test because that is the mainstay of diagnosis. We have to do 2 smears, otherwise that is or 2 smears, and we have to do chest X-ray. Depending upon the finding of these investigations, we have to classify the patient. If suppose the smear or expert, that is NAT, is positive, we have microbiologically confirmed this case. So this is a case of microbiologically confirmed tuberculosis. Suppose the smear and NAT are negative, but the X-ray has findings highly suggestive of tuberculosis. Then it's a case of clinically diagnosed TB because the X-ray is suggestive, but the microbiology could not be confirmed. On the other hand, if the smear and expert all are negative and the X-ray also is not suggestive, then it is not a case of tuberculosis most likely. Similarly, in presumptive extrapulmonary tuberculosis cases, we have to do NAT, culture, smear, and specimen from the specific extrapulmonary site. If any of these findings is positive, then we have to confirm this is a case of extrapulmonary tuberculosis. In some cases like lymphadenopathy or those things, we may undertake cytology or histopathology also, and X-ray chest and other relevant imagings may need to be done also. If findings of any of these more than equal to 1 are suggestive of tuberculosis, we have to stamp the case as a case of extrapulmonary tuberculosis and start treatment. So how do we treat a child of tuberculosis with HIV? HIV infected child with tuberculosis, if we have found, then we have to give 2 HRJD plus 4 HRE, that is the same antitubercular therapy that we give in normal children. But at the end of treatment, we have to give INH preventive therapy or tuberculosis preventive therapy or INH preventive therapy IPT for 6 months after the completion of this 6 months of therapy. That means the total therapy becomes 12 months, out of which the 6 months is the tubercular treatment and the next 6 months is the INH preventive therapy. But similar to the conventional patient, if the HIV patient is a case of spinal or CNS or disseminated tuberculosis, we have to change the regimen to 2 HRJD plus change the regimen from 2 HRJD plus 4 HRE to 2 HRJD plus 10 HRE, that is total 12 months, and we have to always give IPT for 6 months after the completion of treatment. That means the total treatment duration becomes 18 months. Now, what are the problems of HIV TB co-treatment? We have already seen what are the problems of HIV TB co-diagnosis. Now we'll see what are the problems of HIV TB co-treatment. First thing is, rifampicin is a cytochrome P450 inducer and induces the metabolism of non-nucleotide reverse transcriptase inhibitors and protease inhibitors and therefore decreases the therapeutic levels. Second is, increased adverse effects such as hepatotoxicity may be seen because a lot of drugs are being given. Third thing is, bedaquiline is metabolized by CYP3A4 also. Bedaquiline is an antitubercular drug. High pill count, as the child is taking a lot of antitubercular drugs and will also be taking a lot of drugs for antiretroviral therapy, the pill count is very high. That leads to decreased patient compliance and increased loss to follow-up and iris when ART is initiated early. What is iris? We'll learn in a bit. So how do we manage a case or manage a child who is already living with HIV infection or maybe on antiretroviral treatment also? For that purpose, we classify the children into two groups, that is age less than 12 months and age more than 12 months. So basically infants and older than infants. So in children more than 12 months of age, first we have to look for the symptoms, 4 symptom screening strategy that we learned just now, and screen for TB using that 4 symptom complex. If the symptoms are present or if the symptoms are absent. If the symptoms are present, we have to think about presence of active tuberculosis first, then we have to investigate for tuberculosis, like the same investigation strategy like NAT or chest X-ray and all those things. If from those investigations we have found that active TB is present in this case, then what do? We give antitubercular therapy. But suppose symptoms are present, but when we did investigation for active TB, there was no active TB present. That means all the investigations are negative. Then what do? Symptoms are present, active TB is absent. That means we have to give isoniazid preventive therapy or isoniazid prophylactic therapy for 6 months. The point to be noted here is that using the 4 symptom complex, when we screen a child older than more than 12 months already living with HIV, even if the symptom is absent, we have to give isoniazid preventive therapy for 6 months. On the other hand, if the child is less than 12 months, that is it is an infant, then the symptoms may not develop. Rather, more important is the contact history with tuberculosis. If there is any contact history with pulmonary TB present or not. So if the contact history is present, then we have to think about presence of active tuberculosis. That means we have to evaluate. We have to do the investigations. If the investigations reveal that active TB is absent, then we give IPT for 6 months, like in this scenario. But if the investigations reveal that active TB is present, obviously we have to give antitubercular therapy. So that is the thing. So now coming to one important, I think the most important clinical scenario, if a patient with both HIV and TB is diagnosed simultaneously, means suppose the patient has come to you with symptoms suggestive of either TB and HIV, and you evaluate for both and you find that the patient is HIV TB co-infected, then what to do? To understand, to know what to do in such a clinical scenario, you have to understand this concept of what is immune reconstitution inflammatory syndrome or IRIS. So first thing to know is when HIV TB co-infection is there, as HIV is an immunocompromising condition or immunosuppressive condition, the immune system is depressed. The child's immune system is depressed. But when you give antiretroviral therapy, what will antiretroviral therapy do? It will recover the or cause the recovery of the immune system, and a time will come when the immune system will completely recover and it will cause immunological injury as a reaction to Mycobacterium tuberculosis. When you give antiretroviral therapy, the HIV-1 replication gets significantly reduced and the viral load falls, which results in increasing CD4 count and the improved function of the immune system. This improving immune response or improving host immune response to the tubercular pathogen produces clinical manifestations. This is called immune reconstitution inflammatory syndrome. This happens when a HIV TB co-infected child is started on antiretroviral therapy first, because the improving or recovering immune system causes immunological injury. That's why it is important to know that in all the children living with HIV and tuberculosis, we do not begin ART first, we begin ATT immediately. We have to first start thinking about treating the tuberculosis, which is irrespective of the clinical stage and the degree of immunosuppression, that means irrespective of the CD4 count. And after we have started the anti-tubercular therapy, when the tubercular bacillary load is decreased, as soon as the patient can tolerate, that is preferably within 2 to 8 weeks, we have to begin ART. This is the most important thing to know, that we have to start ATT first and then ART, preferably 2 to 8 weeks after starting the ATT. And there are some clinical scenarios where we may think about starting ART within 2 weeks or before 2 weeks of starting ATT. That means slightly sooner. What are those scenarios? Obviously, in scenarios where the patient is very sick and may not survive very long if you don't start ART. What are those situations? If the child is a moribund patient, if the CD4 cell count is less than 50, extremely decreased, less than 50 cells per cubic millimeter for children more than 5 years, any severe forms of tuberculosis, like for example, disseminated tuberculosis or tubercular meningitis like that. So in these scenarios, we have to start ATT, and before 2 weeks completion, we may think about starting ART also. But preferably in other scenarios, we begin ATT first, and within 2 to 8 weeks of starting ATT, we begin ART. So what are the antiretroviral drugs? We have to classify them as three weight groups or three weight bands: less than 6 years, 6 to 10 years, and more than equal to 10 years, or less than 20 kilo, 20 to 30 kilo, and more than 30 kilo. For all these weight groups or all these weight bands, lamivudine is a must. That is the most important thing to know. Now, when the child is up to 30 kilo, we have to add abacavir, and if the child is more than 30 kilo, we have to replace abacavir by tenofovir. Similarly, when the child is less than 20 kilo, we have to give lopinavir or ritonavir. When the child becomes more than 20 kilo, we have to replace lopinavir or ritonavir by dolutegravir. Important thing to know is dolutegravir dose is twice daily for 2 weeks after the last dose of rifampicin, and super boosting of lopinavir with ritonavir to continue for 2 weeks after stopping rifampicin. So 3 weight bands or 3 age bands: lamivudine for all, up to 30 kg abacavir, above 30 kg abacavir to be replaced by tenofovir, and up to 20 kg lopinavir or ritonavir, and after 20 kg or more than 20 kg dolutegravir for lopinavir. So these are the modifications of ART regimen in children living with HIV who are receiving rifampicin based antitubercular therapy. So you can pause and undergo this. There is no point in explaining all this. So what do we do when a child comes to us who is already diagnosed with HIV and already on antiretroviral therapy at the time of diagnosis of active TB? Because we learned that if we diagnose HIV and TB together, we prefer or we should always start with antitubercular therapy, then give antiretroviral therapy. But suppose if we don't have that opportunity, suppose the patient is already diagnosed with HIV and already on antiretroviral therapy, now into the treatment of antiretroviral therapy, at some point of time the child has developed active tuberculosis, then what do we do? First thing to know is ART modification needs to be done to maintain the optimal efficacy. What are the complications we face? I just discussed just now. Active pulmonary TB within first 6 months of ART. If the TB diagnosed now is active pulmonary TB, but it is within the first 6 months of ART, it need not be considered as ART failure. Rather, the regimen is to be adjusted for co-administration of rifampicin and bedaquiline containing regimen. But if the active pulmonary TB has developed after first 6 months of therapy of ART and the CD4 count and viral load are available, the diagnosis of treatment failure is to be considered and decided by above. That means, suppose a child who is diagnosed with HIV, currently on antiretroviral therapy, develops symptoms of active pulmonary disease. So we have to see how long the child has received antiretroviral therapy. If it is less than 6 months, we need to just modify the treatment simultaneously and we may not think about the possibility of treatment failure. Rather, when the child has taken more than 6 months of antiretroviral therapy, we expect the patient should respond by now. But even if after receiving 6 months of antiretroviral therapy, the child has not child is still developed active pulmonary disease, we have to start thinking about the possibility of treatment failure. Similarly, the development of extrapulmonary TB at any point of time in a child of HIV who is on antiretroviral therapy has to be always considered as ART failure and the treatment has to be modified. What are the other special considerations that we have to undertake? Cotrimoxazole prophylaxis therapy has to be given to all. The monitoring during treatment has to be LFT has to be done on baseline on day 15, first month and third month, and after the third month, a symptom directed approach has to be followed. That is, depending upon the symptoms, what investigations we need to undertake. So we learned what is immune reconstitution inflammatory syndrome. So to recapitulate again, the immune reconstitution the inflammatory syndrome or iris happens when in a TB HIV co-infected child you begin ART first rather than ATT, which leads to improvement of the host immune response. That improving immune system gives rise to immunological injury in response to Mycobacterium tuberculosis, which leads to development of more severe symptoms or appearance of new symptoms. That is called iris. This iris is of two types, that is paradoxical iris or unmasking iris. What is paradoxical iris? TB symptoms that have started improving on ATT show exacerbation after the patient is started on ART. So paradoxical iris means the symptoms had started improving, but now the symptoms have started worsening again. What is unmasking iris? The name is self-explanatory. Previously asymptomatic patient now shows the clinical sign of active TB. So this is called unmasking iris. So when an iris patient presents, think about how it will present. Previously, the patient was asymptomatic, diagnosed with HIV, started on ART, developed more symptoms. Or previously the patient was having less symptoms, diagnosed with HIV, now presented with more symptoms. So what can be the other possibilities except iris in this case? That means a patient of HIV on ART not responding or not improving or having worsening symptoms. What can be the possibilities? The possibilities can be poor adherence to therapy, treatment failure, drug resistance, opportunistic infections or development of a neoplasm, or drug toxicity and drug reaction. Like we discussed in our previous video, what are the causes of poor weight gain or causes of clinical non-response in case of TB? Similarly, in case of HIV, these are the differential diagnosis of immune reconstitution inflammatory syndrome. So what is the treatment of immune reconstitution inflammatory syndrome? Mild symptoms need only symptomatic management, but presence of moderate or severe symptoms may require short-term steroid therapy. The drug of choice is prednisolone, which has to be given at 1.5 mg per kilo orally for 2 weeks, followed by 0.75 mg per kilo orally for 2 weeks, and later this has to be tapered, just like any steroid regimen. So now coming to the last slide, but it is very important for all pediatricians and obstetricians also to know, how do we decide on giving the BCG vaccination in a child with HIV or a newborn born to a HIV positive mother. So all this depends upon having a balance of risk versus benefit. If in that particular child the risk of developing tuberculosis is higher, we do not give BCG, and if the risk of tuberculosis is lower, rather the benefit is more, we give BCG. So that is the thing. So first we have to ask, is the mother's HIV status known? Is the mother's HIV status known? Suppose the mother's HIV status is not known. So we have to assume that the mother's HIV status not known means most probably the patient mother does not have any symptoms of HIV. So most likely the mother does not have HIV. So in this particular scenario, the benefit is more than risk. That means the child or newborn should be immunized with BCG vaccination. But suppose if the mother's HIV status is known and the mother is positive, the other scenario in which the mother's HIV status is known and the mother is negative, that actually is not confusing at all. You give BCG straight away. But if the mother's HIV status is known and the mother is HIV positive, then what do you do? Then we have to know if the infant's HIV status is known, because as we know, we cannot exactly do an infant's HIV testing before 6 weeks of age. So if the infant is less than 6 weeks of age, the infant may not have undergone HIV testing. So in those scenarios, we have to ask, is the infant's HIV status known? If the infant's HIV status is known and the infant is HIV positive, that means the infant has undergone HIV testing and it has come positive. That means obviously in this scenario the risk is much more than the benefit. That's why we do not give BCG vaccination in this child. But suppose the infant's HIV status is not known, that means infant has not been undergone any HIV testing. So how do we know if the infant is suffering from HIV or not, or the infant is HIV infected or not? What do we do? What options we have? We have the only one option. We have to clinically examine the patient and see if the infant shows any signs and symptoms of HIV infection. If the signs and symptoms of HIV infection are not there, that means the child or infant is less likely to have tuberculosis, or sorry, the child is less likely to have HIV infection. So what do we do? In this case, obviously the benefit is more than risk. That means we have to give BCG vaccination. But on the other hand, if the child shows signs and symptoms of HIV infection, that means in that particular scenario, the chance or the risk is more than the benefit, and in those scenarios, the BCG vaccination should not be given to that infant. So this is the algorithm on whether and how to decide to give BCG vaccination to a child or infant or a neonate born to a mother with HIV positive status or HIV unknown status. So what are the key learning points that we learned today? First thing is the TB and HIV always go hand in hand and have a complicated clinical interaction. The diagnosis is difficult. That's why a 4 symptom screening approach has to be followed. Always in a co-infected child who has not taken any treatment before, ATT has to be started followed by ART, because if we reverse this, there is a chance of developing IRIS, that is immune reconstitution inflammatory syndrome. Isoniazid preventive therapy for 6 months has to be given to all after completion of ATT course, and if the patient doesn't have any active TB, we have to just give IPT for 6 months. And active pulmonary TB after 6 months of ART or any extra pulmonary TB if already on ART indicates treatment failure and has to be evaluated carefully, and the decision whether to give BCG in a neonate with suspected HIV depends upon the signs and symptoms of HIV in that infant or neonate. So if you like this video, press like, share with your friends and subscribe. Thank you.